Dr. Digvijay is joined in. Dr. Digvijay,
Yes, ma'am, I have joined.
yeah, good morning.
Good morning, ma'am.
Yeah, how are you?
I am fine, ma'am.
Yeah, so your student is presenting today.
Yes.
Yeah, so you all take regular case presentations for them.
Not yet, but
Yeah.
once in a month we have started.
Hmm. Yeah. So our teaching program is on Tuesday and Friday after Wednesday and Friday afternoon, the
Okay.
formal teaching. So if you want, you can send it across. I know
Yes.
DY Patil and Bharati is far apart, but still, I
Yes.
think once or twice, especially when there are cases, we can share our teaching timetable with you, so that they can
Yes.
join us if they want. If you're able to
Definitely.
relieve them, yeah.
On Wednesday we can send because Friday we have a OPD
Okay.
in the afternoon.
So they can coordinate with my students and we'll share the timetable with them. Yeah.
Sure, ma'am.
So it'll be
Thank you.
helpful, I think. Yeah. I'm just waiting for Dr. Nachiket to join actually. Dr. Nachiket, you joined in? Hello? Dr. Nachiket, you're muted.
Yes, ma'am.
Yeah. So we are good to start?
Sure.
Yeah, okay. Hello, good morning, everyone. Welcome to another session from MRA, Student-Teacher Interface. A presentee today is Dr. Taru Sharma. She's a fellow of clinical rheumatology from DY Patil Medical College and Hospital, Pune. Her mentors are Dr. Girish Kakade and Dr. Digvijay Ekbote. Our mentors for today's case presentation are two senior renowned rheumatologists, Dr. Nachiket Kulkarni, he's from Pune. He's a senior rheumatologist from Pune practicing at Jahangir Hospital, his own clinic, and Dinanath Mangeshkar Hospital. He's one of the guides today. The second mentor is Dr. Salil Ganu. He's done his fellowship from CMC Vellore and DM from Amrita Institute from Kerala. And he's at present practicing in Nagpur and attached to the Lata Mangeshkar Medical College and Hospital at Nagpur. So we'll start with the case presentation, and we will have to wind up around by 11:45, 11:50, where we sum up and give a feedback. And after that, we'll have a guest lecture. So it is just like a normal case presentation. The student will present and the mentors can stop in between and ask questions as they wish. Okay, over to you, Dr. Nachiket and Dr. Salil. You can start presenting, Dr. Taru.
A very good morning to everyone. Today I am presenting a case of 55-year-old male with chronic inflammatory polyarthritis, dactlylitis and bilateral pedal edema. So my patient is a 55-year-old male who is married, farmer and drummer by occupation. He is from Junnar, Pune. So his chief complaints are joint pain for 2 years and bilateral pedal edema for the past 15 days. History of presenting illness. The patient had joint pain for 2 years, which was insidious in onset. It initially involved left ankle and left first metatarsophalangeal joint, associated with swelling and morning stiffness in the joint for around 30 to 45 minutes. There is a history of swelling of the left index finger, which was also associated with the pain and swelling in the joints. And there is also a history of left heel pain, which was associated with swelling and stiffness, especially with movement. Pain and swelling responded to the over-the-counter medications taken by the patient, and the patient's symptoms subsided with those medications. Over some time, the patient started to have facial puffiness and weight gain with those medications. Now, for the past 15 days, the patient started having an abrupt onset of joint pain in bilateral ankle, which was followed by metatarsophalangeal joints, which then progressed to involve the left knee, left wrist, left second metacarpophalangeal joint, the right wrist, and the right elbow joints. Pain was severe in intensity and sharp in nature. Pain was associated with swelling and redness of the joints. Patient was not able to use the affected joints and was bedridden after the onset of pain and required support for doing his normal routine activities. There is also pain and swelling of the left index finger with overlying redness. There is a history of low-grade fever which he associated with these episodes, and there is also a history of left heel pain. Patient went to a local clinic where he was investigated and prescribed NSAIDs. The patient's symptoms were not relieved and he got admitted in our hospital. There is also a history of bilateral pedal edema which extended till the knee joint, and on further inquiring, patient had a history of dandruff also. Negative history, there is no history of low back pain or neck pain. There is no history of trauma. There is no history of redness in the eyes or blurring of vision. There is no history of nail changes. There is no history of recurrent diarrhea or blood in stools or nocturnal abdominal pain. There is no history of genitourinary complaints or rash on the palm and soles. There is no history of Raynaud's phenomena. There is no history of photosensitivity and hair loss. No history of Zika symptoms or oral ulcers. No history of frothy urine. No history of dyspnea. Past history. The patient is a known case of hypertension for the past 2 years. He is taking telmisartan plus amlodipine for hypertension. There are no history of any other comorbidities like diabetes mellitus, tuberculosis, CVA or ischemic heart disease, psychiatric illness. Family history, no history of arthritis or inflammatory low back pain in the family. There is no history of psoriasis in the family. Personal history, the patient takes a mixed diet, appetite is normal. Sleep was disturbed due to the pain for the last 15 days. There are no mood changes, and the patient is an occasional alcoholic. He takes whiskey 90 ml twice a week, which he stopped taking 5 months back. And he was also a smoker. He stopped 10 years back. Then socioeconomic status. He's a farmer and a drummer. He's illiterate, married, lives with his wife, one son, daughter-in-law, and grandchild. Annual household income is 15,000 to 20,000 per month, which comes under upper middle class according to modified Kuppuswamy scale. And insurance status, he is uninsured by any government scheme. Now summary, my patient is a 55-year-old male with chronic inflammatory oligoarthritis associated with acute onset of polyarthritis, left index finger dactylitis, enthesitis, and bilateral pedal edema in a known case of hypertension.
Now, doctor, we'll wait here. And can we go? Is this the end of the history, doc?
Yes, sir.
Can you go to your first slide, doctor, now? So the history of presenting illness. There was involvement of left ankle, left metatarsophalangeal joint. What all comes to your mind when you're trying to present this as a history?
Sir,
As you're presenting illness.
for left ankle and left first metatarsophalangeal joint, we will first consider the possibility of gout in this patient.
So first of all, it's an articular symptom. Then you're trying to see whether it's inflammatory or non-inflammatory.
Yes.
And then among the inflammatory arthritis, which group of disorders would have preponderance of onset from lower limb?
Sir, reactive arthritis, gouty arthritis.
Yes.
And psoriatic arthritis.
Can we club all spondyloarthritis group in a single group?
Seronegative SPA.
So we'll finish that. So that involves a whole group of spondyloarths. That would be psoriasis, IBD, reactive, juvenile onset. So which are the, now that we have discussed that, if we talk of spondyloarthritis, which 6 groups come into that disease group?
Ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic arthritis, and undifferentiated arthritis.
That becomes 5. Juvenile. So there's a doubt of whether we would include juvenile spondyloarthritis in this group or it would be a part of GI group. But for all theoretical purposes, we would mention juvenile onset spondyloarthritis even in this group. So now you have lower limb presentation, more distal, that is small joints. So you have given 2 groups, spondyloarthritis and gout.
Yes, sir.
Is that the only list which can start with lower limb involvement?
Sir, osteoarthritis can also involve.
We're talking of inflammatory, doc.
So septic arthritis.
What else would you consider? Septic arthritis, long-standing for 2 years.
No, sir, it can't be possible. RA, sir, rheumatoid arthritis.
Okay.
And
So how many patients of rheumatoid arthritis would have foot involvement as their primary onset of symptoms?
Sir, around 40%.
Are you sure about this answer, doc? If no, then better we say I don't.
No, sir, I'm not sure.
That's a more honest answer. So there's a sizable number who start with with feet involvement, and hence we should not be blind-eyed to the possibility that this group also can start. So three,
Yes.
rheumatoid arthritis. Septic arthritis is so told, as Dr. Ganu said, very unlikely given the chronicity of the disease. Any other?
Anything that starts with ankle, but it's unilateral. What else would you consider when you have ankle arthritis? Classical teaching is that sarcoidosis is a disease that starts with that as a predominant ankle involvement early.
Okay.
But it is usually bilateral. Yeah, what I wanted to emphasize here is, see, you mentioned that first MTP is involved.
Yes, sir.
How was the involvement? If you specify that, it will be better. Like, was it initially episodic and then became, you have written insidious onset.
Yes, sir.
How long did it progress? I mean, were there episodes, because you are considering gout, were there frequent episodes of arthritis there or not?
Sir, it was chronic only after taking NSAIDs, some over-the-counter medications. He told that he was relieved of the symptoms and it started again after stopping the.
So that you'll have to specify as in how long did it take for that to subside, and how frequently did you get? I mean, for how long was the patient completely free of symptoms?
Sir, he told that immediately after stopping the medications, he started again with these symptoms.
Okay.
So is it so that there's a chronic persistent left ankle and left MTP arthritis?
Yes, sir.
On insets does get intermittent flares beyond that.
Yes, sir. Yes, sir.
So that insidious onset persistent would have been another understanding of the disease that would have made us more wiser.
Okay, sir. Okay.
So now Dr. Ganu has helped you understand that sarcoidosis is one. Does it go any further? Does the list end here? So inflammatory arthritis, the onset gives us wealth of information down. Where it starts is very paramount. Can connective tissue disorders group can have low limb involvement? Can SLE have low limb involvement as the first involvement?
Yes, sir, it can have.
So if you restrict yourself only to possibility of gout and spondyloarthritis, you might not think about and not ask about. In your negative history, it was a run-of-the-mill negative history, but there has to be a thought process of why those negative histories have been impounded when we are dealing with a lower limb arthritis evaluation.
Yes, sir.
Okay. Anything apart from what we discussed, Dr. Ganu, to ask? I have another question for the second and third line.
Yes, sir. For this slide, I think we are okay.
Okay. Now, doc, you said there is swelling of left index finger and you left it hanging out there. You have said there is no history of trauma. Is it overarching history that there's been no trauma to any digit?
No, sir, trauma. He didn't mention, only with that he's a drummer. So he mentioned that on and off he used to do drumming in these marriages and all. So then he had these symptoms.
And this left index finger would be hand, right? If that is what I have to understand.
Second left index finger.
Okay. Was it associated with pain?
Yes, sir. Pain and swelling both.
So that needs to be mentioned. And did it have any aggravating or relieving factors?
Sir, it got relieved again with those medications, those NSAIDs he took, and after episodes of drumming, he told that he had this swelling.
So, Dr. Ganu, please go ahead. Yeah.
So, what is the possibility that you are considering here? I think dactlylitis, right?
Yes, sir, dactlylitis.
So what all are the causes of dactylitis that you know of?
Sir, seronegative spondyloarthropathies, sickle cell anemia,
Here, I think it would be better to be more
psoriatic and
specific, like what is more common and what is less. Obviously, all of them can cause dactylitis, but among
the most common in psoriatic arthritis,
Hmm,
followed by reactive, and then followed by ankylosing spondylitis,
IBD as well.
IBD.
Yeah. Hmm. And other than spondyloarthritis?
Sir, it is also seen in sickle cell anemia.
Have we exhausted all possibilities of inflammatory causes? If you have entered the hematological domain, is spondyloarthritis the only group which can cause dactylitis?
Sarcoid arthritis can also cause dactylitis, and gout can also cause dactylitis in some cases.
Okay. Define dactylitis, doc.
Yes, sir. Sir, sorry, sir.
What is
Define
dactylitis?
dactylitis. What would you say is dactylitis?
The dactylitis is the swelling of whole finger, one whole finger or more than one finger, which is due to synovitis, tenosynovitis, and soft tissue edema. Mm.
Okay, so what components come within the definition? One is there is swelling, so there is inflammation.
Yes, sir.
To start with, there is inflammation. Then
Yes.
it is of a digit, so that defines it very categorically. So either it has to be upper limb or lower limb, digits only are involved. Third, it is of the whole finger, so that means it goes beyond the confines of the joint. So
Yes,
it's
sir.
not only joint restricted.
Yes, sir.
Okay. And is it what is it all associated with? Is it associated with pain?
Yes, sir. Pain is present.
Okay. Does it decrease the range of motion of that digit?
Yes, sir. It will decrease due to flexor tenosynovitis. So that range of motion will also be decreased.
So it's paramount that these 5 features, what define a dactylitis, have to be known. Then you would know the difference between inflammatory and non-inflammatory. So can you have answers of painless dactylitis? Examples of painless dactylitis? Painless swellings of finger? And we'll restrict only to rheumatological causes.
Sorry, sir. I don't have.
Okay. So you mentioned sarcoidosis. Have you ever come across sarcoidosis, or have you read the classical description of dactylitis that comes with sarcoidosis?
No, sir. I haven't read it.
So that is one feature. So sarcoidosis can sometimes present without pain, and because of the bony involvement and the surrounding tenosynovitis that comes because of bony involvement, not the tendinous involvement, is why you have the boggy feeling but not pain.
Okay.
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 Hence, the history saying that there is only swelling of index finger in a hand which has been recurrently used. He's a farmer and he is a drummer. So he's been using his hand more often.
Yes, sir.
So then it becomes paramount that we have to differentiate whether this is an occupation related CRPS, complex regional pain, or it is inflammatory.
Yes, sir.
And hence all these other features have to be very categorically known to make it. So not swelling of finger and having pain should not blind you to other possibilities.
Yes, sir.
Okay. The third line, left heel pain associated with swelling, stiffness, especially with movement.
Yes,
Now,
sir.
so it is more with movement, improves with rest. Is that what you're trying to mean with this statement?
Swelling and stiffness, especially with movement. Yes, sir.
So when is the pain most for the individual, for the patient?
So when he's walking, he feels the pain.
What is generally
Possibilities?
Dr. Ganu, please.
Yeah, same. I mean, if that is the case, what are the possibilities that you're considering for this swelling? I mean, what are you thinking about when you say
Enthesitis? We are thinking about enthesitis of the tendo-Achilles tendon.
that will have a different description though. Like enthesitis pains will be more in the morning. They'll be having stiffness. They will improve with movement.
Okay, sir.
That I think history you need to check with the patient. Exactly what do you mean by changes with movement?
Yes.
So specifically if you ask, if you get up in morning, how long does it take for that pain to subside? Usually patients tell like that.
Yes, sir.
The history sometimes is not sometimes, every time is very categorical, doctor, that if it's an inflammatory enthesitis, the patient would say that the worst amount pain is experienced when they put the first foot of the day on the ground.
Yes, sir.
And as they start taking 20-25 steps, they start feeling little better.
Yes, sir.
Okay. Now, so this history needs to be counter-checked.
Okay,
Let's
sir.
say this history is true. So previously he had heel pain, he has been having chronic heel pain. He doesn't recall the earlier characteristic of the heel pain, but now he's saying there is swelling and the pain is only while walking, not while resting, not while the first step. It's with activity the pain worsens. Does that
Yes.
give any new understanding about how the heel pain has progressed?
Sir,
Okay. So what, when you say enthesitis, what exactly is inflamed?
sir, the bony insertions of tendons, ligaments, the aponeurosis and the joint capsules.
Okay. So when you say there is heel involvement, and you are being very categorical in saying that it's heel, it's not the sole. Is
Yes.
there anything you're trying to mean with that?
Sir, heel involvement occurs when the tendoachelis insertion at calcaneus is affected, and when plantar facial attachment to calcaneus is affected, he will have sole pain.
Other
So when,
causes,
sorry, Dr. Ganu,
yeah,
please.
for swelling, heel pain and swelling, as you
Yes.
mentioned, what other things can cause this sort of symptoms like?
Sir,
Not tendinitis is one thing, tendoachilles tendinitis is one thing, but other than that, same structure can have other form of problems.
yes.
Tendinosis,
Tenosynovitis also.
So all structures make up the heel. Let's put it that way. Then you'll understand what we are trying to ask.
Sir,
One is tendo, Achilles tendon. You have answered that.
sir, bony structures like tibia, fibula, and this talus.
That's way far, doctor.
ankle, basically. The joints you are saying,
Yes.
heel doesn't comprise. I mean, the ankle pain patients will be able to differentiate between ankle and heel. So, what else in heel?
Dr. Kanu, you only would need to suggest it.
Sorry?
You only would need to suggest it. I think Dr. Sharma, you are not aware, right?
Yeah, what I was trying to say was tendoachilles tendon insertion site inflammation is enthesitis. That is one thing. With repeated traumas, micro traumas, or tight shoes, you get swelling, and patients often say that there is a mechanical pain there, which is a tendinosis there. You rightly said this tenosynovitis, but those swellings will be more near medial malleolus. Plantar fasciitis, yeah, you are correct. So I think these are few things that
Then there's retrocalcaneal bursitis.
bursitis.
Because the person is a farmer, he's going to stand, he's going to squat, he's going to lift things, and he's going to walk barefoot.
Yes, sir.
Okay. Now, what are the complications of tendoachilles tendinitis? Okay, inflammatory is rupture. So how
Yes.
would the patient report? What were the symptoms that the patient would have once the rupture happens? Okay, is the rupture painful or painless? Okay, I'll take it from the the both traumatic as well as inflammatory tendoachilles tendon rupture is generally considered painless. The patient does not have pain. And if there's a chronic enthesitis and gradually leading to rupture, subsequently, the nature of pain changes. From patient reporting that the pain is on the first step of the day, he starts reporting that there is no pain while putting on the ground. But as he keeps walking, because of the instability of the joint, the pain starts coming by. So the change of behavior from being an early morning onset pain to now being activity related and evening related pain gives us suspicion that are we dealing with tendoachilles tendon rupture.
Okay, sir. Okay.
Okay. Secondly, we talked about possibility of sarcoid. Sarcoid can have bony involvement. It involves talus, it involves calcaneum, and there can be geodes in the bone.
Yes, sir.
Okay, so they can cause sometimes pathological fracture. The geodes themselves or the bony involvement themselves sometimes is not is painless. It can be asymptomatic. The ruptures and the fractures that come with it that lead to pain.
Yes, sir.
So
Yes.
categorical elicitation of history of how the heel pain is very paramount to identify which structure is involved, identify the etiology of the structure, whether it's inflammatory or mechanical, and then subsequently see whether the change in behavior is sign of something new occurring out there.
Yes, sir. Yes.
Okay. The patient started having facial puffiness and weight gain. By anything you wanted to tell by this history, doc?
Sir, he can be on steroids.
Uh,
May have led to these cushingoid features.
Okay. And if we want this to be fit, if steroid is not in the equation and NSAIDs are not in the equation, if medicine is not the cause for the facial puffiness and weight gain,
Yes.
you have a person who has had 2 years of feet arthritis, and now saying that there is anasarca. Anything that comes to your mind, does that change your focus?
Sir, renal involvement can be there,
Hmm.
which can lead to this fluid overload type of.
So how would the facial puffiness of drug related involvement, how would the facial puffiness of renal related, though this is a medicine question, it's in paramount, how would that be?
So renal involvement will start with the facial puffiness first, followed by the pedal edema.
Any diurnal variation, doc?
So it will be more in the morning after waking up, and during the day it will decrease.
Okay. Is it worth to mention that?
Yes, sir.
Okay, so no medicine related events. So you're blind. It seems that you've blinded yourself to the possibility that this is not a renal involvement. This is only drug related the over the counter medication.
Yes, sir.
Okay, so that possibility needs to more thoroughly be assessed whether this is evolution of the disease involving visceral organs or this is drug related.
Yes, sir.
Did he quantify the weight gain?
No, sir, he hasn't quantified. We just checked his previous photographs, so with that we correlated.
Okay, so you have taken his weight on the day of examination, right?
Yes, sir.
Do you recall?
Sir,
You have that in your subsequent
yes, sir.
slides.
Yes. Yes, sir.
So, but they do recall that. And no need
Sir,
to go ahead. You want to
it
go
was
to examination first.
73 kgs.
We might not go to examination at all.
So 73 kgs.
73 kgs. So before the onset of the disease, what was his weight? Would have been a more clinical question to ask.
Yes, sir.
Okay, that would
Also, what I would suggest is, I mean, if you are asking, if you are considering steroids, you should ask history related to other parts, I mean, other features of Cushing's.
Yes, sir.
Have they noticed anything else, stria and or
Yes.
anything
Yes.
else?
Yes, sir.
That would be relevant if you ask, if you're considering that possibility.
Yes, sir.
Okay. So every point, every statement that you make, doc, has significant intonations about what diagnosis we are going to make. We might
Yes.
not reach examination today because we
Yes.
have time out where we're going to finish. We would probably just restrict to history, but we want you to understand that lateral thinking would only be possible when your elicitation of history is apt.
Yes, sir.
Okay. Next slide, doc.
So should I?
Yeah, please read.
For the past 15 days, the patient started having abrupt joint pain in the bilateral ankle, followed by metatarsophalangeal joints, which then progressed to involve the left knee, left wrist, left second metacarpophalangeal joint, right wrist, and right elbow joints. So this was all over the period of 2 days. It was acute onset. Then the pain was severe in intensity and sharp in nature. Pain was associated with swelling and redness of the joint. And patient was not able to use the affected joints and was bedridden after the onset of pain and required support for doing his routine activities. There is also pain and swelling of the left index finger with overlying redness. There is a history of low-grade fever, 2 to 3 episodes past 15.
Wait here. Yeah. So fever was there. Okay. So how would you differentiate between this being an infective flare and this being infection related and this being an evolution of the background disease?
So in infectious cause,
Details of fever,
Hmm.
details of fever would probably would like to tell.
So the fever was a low-grade fever, and he associated fever only with the onset of this. When he had intense pain and swelling, then only he told that fever was there. It was only 2 to 3 episodes in the last 15 days.
Good. What I wanted to drive you to, doc, is the patient is from Junnar, right?
Yes, sir.
Do you know the zoonosis prevalence of what forms of zoonotic infections which can involve musculoskeletal system within that part of Maharashtra?
No, sir, I'm not aware.
Reading
If you
anything
mention
related to that?
Zunnar, it comes understood that you should have read that.
Yes, sir.
Dr. Ganu.
Yeah. I think Sir is trying to tell you that the brucellosis is one thing that probably we should be thinking about.
Yes, sir.
Yeah. And about this pain, like it has progressed over 15 days to all these joints, right? And it has not responded to, I think that has come in subsequent slides, but
Ye-
it has not responded to NSAIDs.
Yes, sir.
Any history of obvious history of steroid being given during this time? Was that mentioned? I think that
No,
will come in subsequent slides, but yeah.
no, sir, no. Sir, only NSAIDs were given.
Okay. So what are infective causes of oligoarticular presentation now that you are practicing, learning in Maharashtra that you have come across?
Sir, septic arthritis, Lyme,
Oligoarthritis.
so brucellosis, second,
Okay.
tuberculosis.
I want to know what you have come across now.
No, sir, I haven't seen.
So you have never seen any infective oligoarticular presentation in your OPD.
No, sir.
Okay. So then we have a theoretical discussion. So what infective causes can present with infective oligoarthritis?
Sir, tuberculosis, Lyme disease, then leprosy can also present.
Okay, if I'm talking of zoonotic disease and I'm talking of acute presentation of inflammatory oligoarthritis,
Yes.
Any other example that comes to your mind?
Sir, leptospira,
One,
brucella,
two, more chronic than acute, but let's say okay.
then our viral arthritis like chikungunya.
Three,
Mm, so then,
we are seeing northern and central Maharashtra crudely and up to Nagar district. So then the chances of rickettsial disease are also very high.
yes.
Okay. And so that these understanding would make you more wiser about you illicit. So ये rickettsial क्यों नहीं है और ये why is it a part of chronic disease? और चिकनगुनिया क्यों नहीं है?
Sir, because rickettsial rash and the fever is
Good.
also
So
continuous.
other system involvement. So there's no cutaneous one.
Yes, sir.
Good.
That liver involvement is also very common in rickettsial.
History. We are talking of history.
History wise,
Okay, okay, sir. Certain fever
fever.
by nature, it's not a high grade fever. There is no rash also present.
I can offset that observation saying that the patient is on steroid and NSAIDs.
Yeah. Yes, sir.
Okay. So whenever there are these zoonotic infections, they are always in clusters. So there will be clustered in the family, clustered in the neighborhood. That's
Yes.
a simple telltale way of eliciting history. कि वैसे ही diseases और किसी को थे क्या आपके इर्द गिर्द में?
Yes, sir.
Somebody in the family, is there any index case from where he could contact trace कि यहाँ से यहाँ तक आया है? If it was solitary, only related with patient, low grade fever, then you can surmise probably it's evolution of the disease.
Yes, sir.
Okay, so this history had to be more correctly identified. Anything more, Dr. Kanu, on this?
I think for this slide, I think we are okay.
Yeah. Next slide, Doc.
So then patient went to a local clinic where he was investigated and prescribed NSAIDs. Patient's symptoms were not relieved and he got admitted in our hospital. There is also a history of bilateral pedal edema which extended till the knee joint. And on further asking, he told that there is a history of dandruff also.
Okay. Again, anything very specific you're trying to identify bilateral pedal edema, that being a symptom?
Sir, again, renal involvement can
One.
cause bilateral pedal edema, and other causes like chronic steroid use can also lead to this, and NSAID use also can lead to NSAID nephropathy. Then
If it's a renal edema, what features would it be? Would it have?
uh,
Would it be painless, painful?
sir, it will be painless.
Okay. Would it have any diurnal variation?
And sir, this on lying down it will decrease, and on working and on walking it will increase, dependent edema.
It has a postural association. It is painless.
Yes, sir.
Now, suppose I say that this is inflammatory, and so how would you differentiate that? So, what would be inflammatory causes in spondyloarthritis and gout and psoriasis and gout, sorry, which can mimic, which can cause pedal edema?
So it can be due to this cellulitis caused by the crystals in this.
Absolutely. So, and in fact, gout is well known to cause pseudocellulitis. It could just
Yes.
be gout-related pseudocellulitis, not infective,
Yes, sir.
but sterile. So
Yes.
this bilateral pedal edema, if it is coming again and again in history, this further association needs to be understood. Was this pedal edema painful?
Yes, sir. He had overlying this redness also, and it was painful also.
So it was
Psoriasis also cause pedal edema.
Yes, sir.
Any other condition, rheumatological condition?
Sir, in
And the
vasculitis,
recurrent pain,
vasculitis also we can have pedal edema.
RS3.
what is the mechanism of pedal edema in vasculitis, doc?
Sir, it is due to
I think it might be a wrong interpretation. Vasculitis would cause glomerular nephritis or crescentic glomerular nephritis. That might lead to pedal edema. Per se, there is no direct lower limb involvement. It can have neuropathy, but that also is not going to be edema.
yes.
Something like Dr. Ganu just mentioned. Do you know what that condition is?
Sir, that seronegative symmetric polyarthritis with RS3 So it is a type of rheumatoid arthritis where pedal edema is present. Sorry, with pitting edema, but it is mostly in the upper limbs, bilateral upper limbs, and boxing glove hands. We can.
It's Dr. Ganu, I might be mistaken. Is it true that it has to be only associated with rheumatoid? Is it a correct
Not
presentation?
really. No.
No, not
It
really.
can be.
So RS3PE is a presentation true enough, but it can probably rarely evolve to rheumatoid arthritis, but it's not a presentation of rheumatoid arthritis.
Really,
In fact, if RS3PE comes to your mind, what comes to your mind? Is it rheumatoid or is it something else?
Associated with something else?
Sir, it is. It can be associated with malignancy.
Absolutely. So that association is more keen about that aspect.
Yes, sir.
Okay. Now your bilateral pedal edema, you later on have given a different drug history that the patient is on hypertension,
Yes.
and which medicine is he on?
Sir, amlodipine can again cause pedal edema.
So how would be amlodipine related pedal edema?
Sir, again pitting type of edema, and it will be painless. And mostly it will be up to the ankle only. It will not involve till the knees.
Does it have diurnal variation?
No, sir, it will not have diurnal variation.
Absolutely. So no no diurnal variation and no pain. This could just be amlodipine related edema.
Yes.
Okay. So those features have to be very categorically mentioned. Now
Yes.
about hypertension, since how many years the patient has hypertension? Then you can go to the next slide now.
2 years.
2 years. When you take a history of hypertension, please go ahead. What all features in capacity of physician you would want to know? Which is even more paramount from rheumatological cause.
Sir,
Okay, you would want to know how the hypertension was diagnosed. What was the clinical premise on which blood pressure was checked?
yes, sir.
So was it an accelerated hypertension? Was it an incidental detection?
Sir, it was incidental only.
Because too close an association of onset of blood hypertension and his symptoms.
Yes, sir.
Okay. So could there be any association between hypertension and lower limb oligoarthritis now evolving into asymmetric polyarthritis, also having pedal edema?
Sir, both psoriatic as well as gouty arthritis will have this comorbidity, which is hypertension can be a comorbidity in psoriatic arthritis. It can lead to this. It can be present more commonly in this.
If a clear capsule is heard by you that there is a 2-year rapidly progressive inflammatory asymmetric polyarthritis and simultaneous onset hypertension, would you consider hypertension a part of the disease or a part of comorbidity and try to identify the cause of hypertension?
Sir, it would be considered as a part of disease.
So tell me diseases which can then explain this phenotype.
Sorry, sir, just can you repeat the question?
So which causes can have inflammatory polyarthritis and hypertension as presentation? I'll rephrase it as simple as this is.
Sir, psoriatic arthritis, SLE, systemic sclerosis also.
So what would be the mechanism of hypertension in SLE if it has to be a presenting feature?
Sir, again, renal involvement in SLE can lead to hypertension.
Absolutely. So if there is a simultaneous involvement of a musculoskeletal inflammatory disorder and hypertension, your eyes and your ears have to be standing up and try to excavate every possible involvement, that whether we are seeing a glomerular involvement.
Yes, sir.
Okay. So give causes of inflammatory diseases which would have hypertension and inflammatory polyarthritis as presenting features. SLE, you have told one. Yes.
Systemic sclerosis also.
Presenting as hypertension.
In case of renal crisis in systemic sclerosis.
Rare presentation, but I will not discuss this talk. It's a different thing altogether to discuss. Any other? Which diseases can cause renal involvement and inflammatory
Dactlylitis also
polyarthritis?
can.
Which diseases can cause renal involvement and inflammatory polyarthritis? Let's make it even more simpler.
Sir,
First thing you were mentioning in previous slides, vasculitis.
yes, sir. Vasculitis like Wagner's granulomatosis.
All can, no, doc? All three,
Yes.
ECG, GP.
Sir, Sjogren's also
Basically,
heartburn can
small
occur.
vessel vasculitis, any form of small vessel vasculitis involving kidneys,
Sir, ANCA related vasculitis.
all of them.
Yes.
So, just to see whether your understanding of vasculitis is apt, what is the classification of vasculitis?
Sir, we have small vessel vasculitis, medium vessel, and large vessel.
Who has done this classification? Okay, Chapel Hill, you need to review that. Is there any other fourth group? There's a fourth group by name variable vessel involvement related vasculitis.
Yes.
Are these all vasculitis very watertight? कि जो middle vessel है वो small vessel लाता ही नहीं है. जो
No,
small
sir.
vessel.
No, sir.
So that understanding has to be there. That phenotypically most likely they might not, but they're not watertight. Can a large vessel vasculitis present with hypertension and inflammatory polyarthritis?
Sir, Takayasu arthritis.
I'm not asking which forms of Takayasu. I'm asking what are large vessel vasculitis that I know you very well know. Can this be a presenting way? Asymmetric polyarthritis and hypertension.
Yes, sir.
No. So then when you're trying to say that these two things are coexisting, all forms of inflammatory involvement come in picture.
Yes, sir.
Okay, doc. We can probably go through your examination fast. Dr. Gano, if it's okay, I think we are short of time now.
Yes, sir. Yes, sir. Sure, no problem, sir.
And we'll summarize 2 minutes on her examination then, how she examines dactylitis, if that is what the case today actually is.
Sir, should I start from the beginning?
Yeah. Start from general examination. That's okay.
Sir, our vitals pulse was 74 beats per minute, regular, normal volume, normal character, no radioradial and radiofemoral delay. All the peripheral pulses well felt. Blood pressure was 130 by 18, right arm supine position. Respiratory rate was 18 cycles per minute. Temperature was 98.6 degree Fahrenheit. Height was 160, weight 70, BMI 227.3. Waist to hip ratio was 1.06. Then general physical examination. Pallor present, bilateral pitting pedal edema present, no history suggestive of icterus or lymphadenopathy. Then sir, hair में there was excess dandruff, eyes were normal, oral cavity normal, nails में some hyperkeratosis was there was no pitting. Hyperkeratosis mainly in the lower limb nails. Skin में tinea cruris was present, acanthosis nigricans was there, some skin tags were also there. Face puffiness was present, back buffalo hump was seen. Then in musculoskeletal examination, tender joint count was 12 and swollen joint count was 10. And the joints were red and warm to touch. This is a figure showing left index finger swelling, suggestive of dactylitis. And this is a figure showing bilateral limbs of the patient, which are showing this bilateral pedal edema as well as redness over the knees and the ankles, plus the first metatarsophyllangeal joints. So then again, it is a picture showing the bilateral pedal edema of the patient, and nails are also showing some this hyperkeratosis is seen.
Describe the hyperkeratosis of psoriasis, doc, and how does it differentiate with teniasis?
Sir, hyperkeratosis is excessive this.
No, describe what are the differentiating features of hyperkeratosis of psoriasis and teniasis. Okay, it is always subungual in psoriasis. It can be suprangual in teniasis. There is always associated dactylitis or nail bed inflammation in psoriasis, because there is where it starts.
Yes.
Nail bed might be free in fungal.
Yes, sir.
Okay. What are other features of nail involvement in psoriasis?
Sir, there can be pitting, there can be onycholysis, then oil drops or.
So the onycholysis or nail fracture, is it a feature of teniasis?
No, sir.
It is not.
No, sir.
Okay. So there is inward turning. So that's how we would differentiate between teniasis and psoriasis. Go ahead, doc. I will go ahead fast because we just wrap up the examination.
Yeah, you have to wind up.
The dactylitis of the left index finger, and left MTP joint dactylitis is also seen on examination. Left tendo-Achilles tenderness is there, and no SI joint tenderness or Faber's test is also negative. Then systemic examination normal. Then summary after examination: a 55-year-old male having chronic inflammatory oligoarthritis with superimposed acute asymmetric polyarthritis with enthesitis, dactylitis, and bilateral pedal edema in a known case of hypertension. The differential diagnoses are crystal arthropathies and psoriatic arthritis.
Go behind. So you're trying to mean that the chronic inflammatory oligoarthritis is a different disease subset. The acute symmetrical polyarthritis is a different disease subset.
Yes, sir.
And why is it so? So what are these two different diseases? Now that you have already.
Is there any association like?
Sir, it is this gout with the psoriatic arthritis, most likely. Overlap of psoriatic arthritis and gout.
Why does why is the prevalence of gout more in psoriatic arthritis?
Sir, because of the increased epidermal turnover in psoriasis, the purine this burden increases in the body and leads to hyperuricemia.
So for that, you should have actual significant skin involvement, right?
Yes, sir.
For that amount of turnover.
Yes, sir.
Is that amount, how much is it PASI?
Sir, can you repeat?
PASI score?
PASI score, have we taken a doc?
No, sir.
So every case of psoriasis, the PASI score has to be there.
I think
And
Dr.
generally,
Nachiket and Dr.
Yes,
Ganu
ma'am.
will have to wind up in 2 minutes, including feedback. We can have a part 2 next time if you want.
Sure, ma'am.
Yeah.
So, in my understanding, and I'll leave it to your own mentors to discuss, even though there might be two different diseases coexisting, the ultimate summary has to be composite of the overall musculoskeletal picture. So probably it's, you could have presented a 55-year-old farmer presenting with insidious onset chronic inflammatory oligoarthritis, now evolved to a asymmetric polyarthritis with features of enthesitis, dactylitis, and you have forgotten the nail involvement.
Yes, sir.
And forgotten the scalp involvement.
Yes, sir.
So that has to be part of your summary.
Yes, sir.
And then in that feature, the psoriatic arthritis probably would be the first diagnosis and crystal would be second, if at all it is there, which I doubt it might be.
Okay, sir.
Okay, Doctor, I'll rest my presentation. Dr. Ganu, if you have any inputs, please.
Yeah, I think we are okay.
Okay, Dr. Ganu, any
Joint
feedback?
aspiration.
Yeah,
We
okay.
saw these
Have that,
yeah.
yeah.
Criticals.
Yeah, I think it was going very well, but we have a little shortage of time. Any feedback, any of both the faculty want to give her for further case presentations?
I've exhausted my time. I'll revert to Dr. Ganu. Please,
Yeah,
Doctor.
Dr. Salil, yeah.
Yeah, I would like to reiterate what sir said during this thing. The history part needs to be, quite precise. Although you have covered everything, I think as the things that we have discussed, that should be considered in subsequent cases.
Yes, sir. Thank you, sir.
Yeah, so I
It's
think
good.
Dr. Taru, you have learned a lot from both the mentors today.
Yes,
Every line, every symptom needs to be taken into detail. And then your diagnosis will be already there on history. So thank you, Dr. Nachiket. Thank you, Dr. Salil, for sparing your precious time on Sunday. I think it was one of the best case presentations, and the history taking was really well taken. So thank you so much. We go on to the, I think Taru, stop sharing your slides, please.
Yes, ma'am. Yes.
Yeah, and Dr. Shanmuganand, you can start sharing your screen.
Yes, ma'am.
So it gives you great pleasure to invite and introduce Brigadier K. Shanmuganandan. He's an old friend because he was posted in Pune for a long time. Right now he's based in Chennai. He's a professor at Sri Balaji Medical College and Hospital, Chennai. He has 90 publications to his credit. He is a part of 12 research projects, including ours on which we just completed. Now we're doing data analysis in bone mineral density in rheumatoid arthritis. And he's really fond of teaching, and he's got a teaching experience of 28 years. Welcome, sir. And today he shall be speaking to us on PET-CT in rheumatology, a case-based discussion. Welcome, Dr. Shanmuganandam, and you can take over to you, sir.
Yeah. Good morning, and I'm so happy. And thank you, Kavita ma'am. And we have a long association from the Pune days, and you also have a 4G background.
Yes.
Like me, I was in the army for 32 years.
Mm.
So today, what I will do is, I would rather take it in a different way. What I am going to do is little more informal, instead of going into the theory and the mechanisms of it. I will just tell how PET-CT helped me in the clinical practice over the years by the way of simple cases, that will be more impressionable and memorable to you all. So what we always say is, whenever patient comes with joint pains, the possibilities are numerous, So another way to put it is to study the phenomena of the disease without books is to sail an uncharted sea. But while to study books without patients is not to go to sea at all. So patients are the central point of our entire profession. And this is the Akash Tir, this anti-air defense, which has knocked out most of the drones. It is precise and it is fast. So just like that, PET has turned out to be a very, very precise and good investigation in the diagnosis of inflammatory disorders. not only in rheumatology, but beyond that. And many times there is a overlap or an interface between, of course, general medicine being the prime mother specialty, and many oftentimes patients do come with complicated symptoms. So my interest actually with regard to PET, again I had a Pune connection. Dr. Solo, who is the nuclear medicine specialist, just installing that in the early 2000s, and subsequently we also had PET, but it was a little difficult thing, so I thought. So when I became the professor in Army Hospital, and one of my students came with this, the use of FDG PET to quantify the disease burden in patients with spondyloarthritis and TNF, because many times MRI is little difficult to interpret, and there are all the sequences are not been done, and many a times in spondyloarthritis, especially people on treatment, the acute phase reactants and the symptoms don't help. So initially we had a good, this being an observational study, I was quite fascinated because the PET picked up a lot of lesions which is not otherwise picked up elsewhere, the sacroiliac joint, the sternocleidomastoid joints, the enthesitis, and all that. So that was my introduction to PET. But subsequently, I'll be showing certain simple cases where PET was being little helpful in the diagnosis. So before we go there, I just want to give a brief overview. It's quite interesting. Most of the advances in the field of radiology and medicine has come through physicists and basic scientists. And this PET thing has been there right from the 1930s, when there was something called as a Warburg effect. And subsequently, Kubota et al. Just found out that in if you use radiopharmaceuticals and they decay when they injected, when they undergo beta plus decay, they produce what is called as positron, which are just like electron but positively charged. And they, when they positron is emitted and it's interacts with a normal electron, the two particles annihilate each other and two gamma rays are produced. This is a basic principle in which you can use that to scan and make it as a FDG scan, plain FDG scan, which is the sort of technetium bone scan type of standalone scan. But when you marry it up with CT scan, then what will have is you have more depth, anatomical details, and with fusion of these images, this hybrid molecular imaging can be of much use. Initially, it was being used for detection of cancers initially. And this is the history, very, very, very important. As late as 1991, there is a Journal of Nuclear Medicine which has said that clinical PET, its time has come. Possibly it was still in the development stages till the 90s, and till at least end of 2010s, it was mainly used for, or even 15, it was used only for cancer. If you think it was, it is PET means they used to think it's only for cancer. The very word, if you ask the PET person to do a PET scanning, the patient used to be very afraid, very thinking, and maybe that I'm developing cancer and we want to rule out cancer. Many would not get it done. So there are a lot of physicists, basic scientists, which has gone into the development of PET by the introduction of cyclotron and various radiopharmaceuticals. And what we have now is much, much more advanced. Though we have PET MRI and much advanced, but what we have for clinical practical use is the PET CT. And as you well know, without going to much theory, we know that PET is a very important armamentarium in the diagnosis of FUO, that is a pyrexia of unknown origin. And many times it's up in the diagnostic armamentarium. And because many tests have already been done by the time they reach the subspecialty or the rheumatology center. And it's definitely helpful in delineating what is the cause of pyrexia of unknown origin, which can be very vexing, and even up to 10% we cannot make out even after PET and all that. So the basis of all that is the inflammatory tissue uptake of glucose. And this is the actual technology, pathobiological basis of PET in inflammation. Basically, as I told, it's a molecular imaging technology. It is a combination of physiological and anatomical, which can lead into accurate diagnosis and precise treatment. Basically, deoxy 2,18 fluoride D-glucose or 18F-FDG phosphorylated into 18F-FDG 6-phosphate by hexokinase, and macrophages require high glucose. So if you use this tracer, there will be an increased uptake of 18F-FDG in the inflammatory lesions, and therefore with this input, it has come into the clinical realm in the diagnosis, follow-up, and measurement of activity in various rheumatological disorders too. As far as this is again another thing in FUO. Even today, the bulk of the PET in non-cancer situation is being done in the PUO, where it's got a very high sensitivity, specificity. It's a little less because it cannot specify what type of lesion it, but it can home on to just like this missile. Where's the problem so that we can biopsy it. And another important thing is it's got a very high negative predictive value when the situation is little tense and patients not doing well with fever and other features of organ involvement. We need to resort to this investigation. So let me come to the brass tacks. Just give a few clinical inputs into the various cases which I've seen. I'll be brief with each case. This was a 32-year-old sportsman, which he had come with third lymphoma relapse. He had lymphoma once, which was given R-CHOP, then second with some other regimen. Again, he came with new onset of polyarthritis and weight loss and PVO. And as we did a PET, we found a lot of inflammatory type of lymph nodes, which everybody thought it was part of lymphoma, but the APR were extremely high and ferritin was very high. So I was just actually searching the net and came across this chronic active EBV infection, which I came to know that it's a new entity which has been increasingly described, and wherein you have it's an oxymoron. It's a chronic but active EBV infection, which can either lead to lymphoma, and it can cause a lot of inflammatory symptoms. And usually the profile is, this is the profile of various type of immunological antibodies, which you can see in a EBV infection. Like this Epstein-Barr virus has got a lot of antigens, like viral capsid antigen, early antigen, and EBNA, Epstein-Barr nuclear antigen, IgG, IgM. In addition, there is a EBV DNA PCR. Well, we have this monospot as a basic test. So if you see this graph, we can see in the primary infection, we have only the viral capsid antigen and early antigen, and the EBNA-IG is negative, and EBNA being acute infection, EBNA-IgM will be positive. And if there is a past infection, like many of us are exposed to this EB virus, oftentimes you have a viral capsid antigen and IgG and EBNA-IgG. In this chronic active EB infection, what really happens is there has been an infection, but is persistent as evinced by this EBNA-IgM. There is a chronic reactivation combined with inflammatory markers, and if it's persistent, it can lead into malignancy. So there's a thin line: infection, inflammation, and malignancy in a one spectrum of chronic EB infection. And there are certain criteria for CAEBV. It is not still well reported. Oftentimes they are missed because the oncologists do not prefer saying that lymphoma itself will cause a raised CRP and all that stuff. They do not evaluate in detail. So this is another case which was flown from the border. It's a commando who was working in the border. He had severe PO and headache. They had done all sorts of tests in various command hospitals and military hospitals. He was flown to RR because he had very severe high-grade fever, headache. They had done the LPs, imaging. Nobody could make out. And they asked for our opinion. And we did the regular test. And something felt that I was not able to get the diagnosis. So I went one afternoon and found he was shivering and he had a severe headache. When I carefully re-examined him, again took the history, I found a lot of redness in the ears. So the diagnosis was pretty evident. And but he also complained of little pain while speaking and all. So we just thought maybe it is a case of a relapsing polychondritis, but with a monophasic initiation. So we did the PET. Here you can see the redness of the eyes, and he had the tracheal inflammation and periaortic. As you can see this in the PET, it was subclinical tracheal involvement and subtracheal aortic involvement. And of course, he responded to steroids with no recurrence. And there are clear criteria, and FDG is oftentimes used for just to see the extra cartilaginous involvement like the aorta and all that. Oftentimes, one should remember that secondary polychondritis due to variety of systemic connective tissue diseases is also very well described and known. And this is another lady. This type of cases often you get in corporate hospitals where they not generally admitted and they go from subspecialist to subspecialist. So many times we get this like this lady with just fatigue and little weight loss, nothing else. Even the ESR, CRP not weight raised. And once you do a PET for weight loss, fatigue, and all that, you can see the typical pattern of the lambda pattern of sarcoidosis. We had more than 15-20 cases to pick up sarcoid, and we are quite high up in the chain to do a PET for localization of the lymph node, and which can be easily accessible for biopsy before we start on therapy. And not only that, we can look for various extrathoracic organ involvement, extent of the disease, and oftentimes it can guide us to biopsy. And with the biopsy, we are able to get to the diagnosis. And ACE levels are only positive in about 20 to 30% in our part of the country. So early diagnosis, extent of the disease, extrathoracic disease, atypical disease, and sarcoid is very important. So as I said, it can detect active inflammation, and it can differentiate between ongoing inflammation or fibrotic or burnt out sarcoid. And especially in cardiac sarcoid, when the patient has come with arrhythmias and there is some device, there may be a contraindication for MRI. Then PET is very, very helpful. And the sensitivity of cardiac sarcoid is around 84%, and that is increasing being detected. And this is another very, very interesting case. Because I was in an academic situation in Army Hospital. Oftentimes, just to teach the residents, we sometimes, I would say, do certain investigations which may not be really evidence-based requirement. But it's very interesting. This lady just came for a general medicine consult, nothing concerned. She had a painful increase in the appendectomy scar of 2 weeks duration. And we did the PET. I just read somewhere and maybe I thought it's sarcoid. Sometimes you do get intuition. And of course, it was a revelation. You can see by the PET where the appendicectomy scar is glowing. Subsequently, on further reading. You always keep learning every day. And in skin manifestations, we know about the Lofgren syndrome, erythema nodosum, and sarcoid like lesions on the face, lupus pernio. But there is much more than that. Like sarcoidosis is very rare. There is actually a reactivation and redness of old cutaneous scars, and it can manifest in various ways. Either after a IM injection, a site, tattoo scar, blood donation, venipuncture, herpes zoster scar, and various tattoos and ritualistic scar. And sometimes it can be little different also. This is a young boy, he's a student. He came with a lot of Google research, and he had a non-healing ulcer. He has been treated with tuberculosis antibiotics. He actually came and said that I have done extensive research. Could it be sarcoid? Because I don't have any other fever or something. They have ruled out tuberculosis. I said, let us evaluate, let us biopsy it, and let us do a PET. And of course, PET was more of academic interest. We did the flare in the PET CT, and we did the biopsy from the area of maximum intensity. And of course, we had sarcoidosis, and he was AB negative. Always remember, tuberculosis, always, it's a mimicker for sarcoidosis. Please do the gene expert and take a ID consult whenever we are going to start steroids for sarcoidosis. This is just last week. I got a huge male, 125 kgs. He came with this type of scar. Like he had tattooed about 5 years ago, and he said that the tattoos have become painful, itchy, and it's become, can say, raised with some raised lesions on the tattoo. And of course, he had some vague joint pains, and all the inflammatory markers are raised. And many specialists had referred dermatologists, ID specialists, pulmonologists. But moment they came, I said, this is just sarcoid. Don't have to wait. Do a PET, prove it, and there is increased uptake in those scar regions. And of course, the ACE levels was little high. But the interesting thing is, he had very high inflammatory markers, hypercalcemia, and little azotemia, probably because of hypercalcemia, and transaminitis. And with simple steroids, he is doing absolutely well, and he is asymptomatic now. So this is another interesting case where it is this one. Just to show that, sorry, just to show that how sarcoid, cutaneous sarcoid is often missed from our group. We generally go by the thoracic and then extra thoracic sarcoid. And PET is actually helpful in localizing the lesion, biopsy, extent of the lesion to do what organ system is involved. But as I said, it's not specific for sarcoidosis. It can mimic malignancy, lymphoma. So PET is not that specific, but it's very, very sensitive to pick up the lesions. Okay. So this is just to remind, sarcoid is one of the important indication for to diagnose for occult extrathoracic disease, targets for tissue diagnosis, non-invasive marker of disease severity, and sometimes you can differentiate fibrosis, of course, in cardiac sarcoidosis and cutaneous sarcoid. Then this is a patient from Orissa I had about 10 years ago. He was a octogenarian and brought by son. He was a lawyer, but he has gone to everywhere. The only thing was he has raised ESR and CRP 112. They gave steroids elsewhere. It didn't work and all that. We did a PET and found a lot of inflammation in the aorta, and in the ultrasound also revealed temporal arthritis. So we had to resort to tocilizumab. But the odd thing was he had this symptoms for a long while, 4 months. And of course, with tocilizumab and a combination with steroids, he became well. And this is a very common, oftentimes, which we do PET. It's a common garden variety of Takayasu arthritis, but with that only the involvement is in the descending aorta. That is little odd, but we do get it. We may not be able to prove that it is Takayasu, but with the claudication, pain in legs, weight loss, raised APR, and abdominal angina, we were able to rule out IgG4 and other causes, and then we were able to get aortitis and atypical Takayasu aortitis who responded to treatment. And just 2 months back, we had this lady who came acutely to the emergency with only severe low back pain radiating to the leg. That's all she had. And ESR CRP was elevated. MRI spine was normal, abdominal ultrasound, and all that was normal. But since the raised APR was there, we directly did a PET where there was a lot of inflammation in the aorta. So we thought possibly it's idiopathic aortitis with inflammation and because of the ischemic pain. And once we gave steroids, all it went. Though the subtle findings are there because of the in the aorta. And next, you can see the IVC. The intake is more in the vertebra and in the spleen also. Kidney, but if you see there is a rim of increase intake in the aorta. So we made it as idiopathic aortitis, and patient did not want any other further investigation. So we had to take a permission and give a steroid course of steroids, with which he became better. And this is another interesting case. You had multiple comorbidities with diabetes, hypertension, hypothyroid. She present with acute history of fever, rash, and complete alopecia in 2 weeks, and a weight loss of 10 kgs in 2 weeks. And on evaluation, she had only some nodular lesions on the eyebrows, ear, and in the hands. And the biopsy again showed some vasculitic picture. So we're wondering some granuloma and vasculitis of the vessel. We were wondering what type of vasculitis it is. And CRP was whopping high, and TLC was high. All features of inflammation are there, but none of the antibodies are positive. There is no complement, hypocomplementemia, nor there's renal or lung involvement. And once we did the PET, we found extensive vasculitis of, as Dr. Nacheket sir also said, but many times these vasculitis are not compartmentalized. They can overflow into the either one. But here we had all types, small vessel, medium vessel, and large vessel. We were wondering what can be the cause. Because it didn't look like pan also, we were just wondering what can be there. And but however, she responded to pulse steroids because she was having hypotension, SIRS. So we thought we will give a course of steroids for vasculitis, and she became well. And as we reduced the, we had to give rituximab and subsequently mycophenolate. 6 months down the line, she was in remission. And again, he had a similar complaints with the same. Of course, we didn't do the PET, but she again had fever, nodular rash, and again alopecia, very rapid. Then we again went in the history. Oftentimes we make the history, we make the mistake of not retaking the history. And this time also we found the common link to be 6-APA. That is, earlier she was given cephalosporin, and this time she was given ampicillin. So only thing we could conjecture that it's possibly a drug-induced vasculitis, that too the penicillin group of drugs. Because again, when we stopped, we again gave the medicine and told her not to, because 2 times it has happened. And possibly, we have checked the literature also, we did not find such type of extensive vasculitis. We had even evaluated by clinical exome if there is some genetic defect, but in this case it was neither. Every time what she used to have is a ferritin going up to tens of thousands, CRP going beyond 200. 2 times she has had this. So that is again, here we could at least find out the severity of the disease by this PET. So this is again a case where patient came with breathlessness, and she had this very dirty lung, and there was a pneumomediastinum, and he did not have any muscular symptoms. But when we did the PET, there's a lot of uptake in the deep thigh muscles. So it is basically amyopathic dermatomyositis or hypomyopathic dermatomyositis who presented with pneumomediastinum. And about 4 years ago, this young man came for right eye swelling from the eye institute, saying that we are not able to pick up any inflammation. Just you find out if there is some vasculitis involved or vagueness or something. But when I took the history, I found that he had features of myositis, and that was the first time about 4 years ago during the coronary time. After the vaccine, he had developed these symptoms, and of course, with the PET, we could find out a lot of inflammation all over the um, 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 muscles, and it's important that anti-NXP2 there is association of malignancy. So PET also will detect if there is a occult malignancy which is there. This is another lady came with classical features of dermatomyositis. But what happened is when we did the PET, we found a neuroendocrine tumor. This association is not described, but the oncologist said that you need to just leave the net because it was not symptomatic. We went ahead and gave her B cell depletion therapy and steroids, and she's better. So PET has revealed that net tumor and neuroendocrine tumor in this case. And sometimes you can, again, while evaluating of fever, we found in this case a little bit of myositis. And subsequently, somebody had done, we got the antisynthetase syndrome. And in idiopathic inflammatory myositis, oftentimes we land up doing a PET because we need to rule out occult malignancies, but it's not come into the main realm. We have a lot of retrospective studies, and it's not still included in the classification criteria because the problem in PET is the availability and the cost. So it is not abroad, at least it's very expensive. And here, of course, we have what is called as inflammatory PET. And just to allay the fear of the patients, we have coined a new term called inflammatory PET, so that they don't think it is malignancy all the while. And another lady had come from US. They had been treated in US for more than 6 months, sorry, about 4 or 5 months with progressive jaundice. And she's a known case of rheumatoid, but she's having a jaundice. He was extensively evaluated in the US, but they couldn't diagnose. So it came to our institute, and as we took the history, they said that it formed after the vaccine. She took the vaccine, that is the Moderna vaccine. Probably it was a third or fourth dose. After which we evaluated thoroughly and came to the conclusion that it's a post-COVID vaccine inflammatory cholangiopathy, which is well described, and we were able to home on only because of PET, and all she needed was a course of steroids, and is still doing very well because she presented with progressive jaundice, which is sudden and onset. 2 or 3 institutions in the USA could not diagnose, which was little surprising. But here again, it turned out to be a inflammatory cause. So post-COVID cholangiopathy, I did not know much about it. Liver injury is one of the non-pulmonary manifestation, and it's a special entity of liver injury that has been suggested as a variant of secondary sclerosing cholangitis in critically ill patients. And normally they say that the prognosis is poor, But however, in our case, we could save, possibly because it may be because of the vaccine and not because of the COVID virus per se. So this is the mechanisms of various causes and various causes of liver damage in COVID-19. We still have the effects of COVID-19. It seems like a dream, but remember that 2-3 years of real tumultuous time all of us healthcare workers had. And there's another young boy who has been symptomatic for 4 years. He came with recurrent swelling of mandible. So long as he was with the pediatric domain, he was being treated as tuberculosis, osteomyelitis, and infection, alveolitis, and they came to me because he is getting these recurrent lesions, and I thought of CNO actually, and the PET also suggested non-bacterial osteomyelitis, and though the exome sequence did not reveal any of those periodic fever subtypes, but the on evaluation IgG4 was raised, but I am not sure if it's IgG4 related CNO or just because of the CNO, the IgG4 was raised. But he responded only to NSAID dose, and he's been, it's a milder variety. And after the started the therapy with, because we don't have guidelines for treatment, we gave a short course of steroids followed by NSAIDs. He remained asymptomatic. But after 2 years, he had recurrence, so we had to put him on Folitrax, that is a methotrexate with a combination of low steroids, and he's been doing well for the past 2 years. Another interesting case, only few cases are there. I'll be finishing in few minutes. Is our own Army Medical Corps officer who was posted in the Valley. He was a general duty medical officer. He came with weight loss, pain, abdomen, and loss of appetite. And on evaluation, we found the APR. They've been seen by various specialists. And on PET, we found increased uptake and retroperitoneal shadow. So we just made a clinical diagnosis of IgG4, and the biopsy from that area, from the retroperitoneal mass, lead to the typical histology of IgG4 disease. We had to give him a course of mycophenolate followed by rituximab, and he's now asymptomatic for 8 to 9 years, but he's on periodic follow-up. So IgG4-RD, it's got a protein manifestation recently described. There is the old Mikulic's disease, which is renamed as IgG4, and it has got a variety of manifestation, and it will go to various specialists like pancreatitis and salivary swelling and all that. And this is actually Bo Koinagi Harada syndrome, who came with multiple swelling, and the aspirate revealed Burkholderia. For academic interest, we did the PET that shown disseminated lesions all over the body who responded to therapy. And sometimes we do find interesting findings, or rather, this is the young CEO who came with the known case of IBD and arthritis, enthesitis, and sacroiliitis. He had severe weight loss, and we did not do PET for that. They were evaluating for any malignancy because he had a sudden onset of weight loss. Here you can see both the sacroiliitis and the inflammation in the small bowel. And only a few more. Again, 80-year-old man with PMR, weight loss, and raised ferritin. And another lady, 23-year-old lady with polyarthritis and normal acute fate reactants. And This is again tuberculous abscess in the presacral region with adenopathy. Again, PET picked up all that. And I finished with the list of interesting cases. I hope it was all interesting and revealing. But before I go, there's a lot of research it's going. This is what we talked of was only 18FDG pad, but there are other radiopharmaceuticals which are more specifically targeted, but they are all in the research realm and not in the real clinical um, use. It's not there. And there are various advantages and disadvantages. I'll not go into the theory, but just to remember for the resident, when do you think about FDG? This is about 10 years old journal, but still holds good. PET, when do you do, at least in our general practice, when do you think is, of course, for PUO mainly, whenever you suspect large vessel vasculitis and in various types of infections which are not normally picked up by other images. And of course, in sarcoidosis, one interesting use is in sometimes very difficult if there is a intravascular device infection where you cannot do conventional imaging. And there are a lot of conditions where it's still unclear, but some research is still needed because they are not specific. So that is important. And so what I have given is just a mixture of or a salad of various diseases like sarcoid, large vessel vasculitis, infection, IgG4 disease. I have not touched upon retrovirus due to the want of time. But nevertheless, these are my clinical beginnings, which I encountered in rheumatology, which had been helpful in at least reaching a conclusion and starting the treatment. Otherwise, the patients were going from pillar to post. Some finality was reached, and we are able to treat these patients well. Thank you. And this is the my guru, we can say, who has been inspiring all along. And I thank Kavita ma'am for giving me an opportunity to give a clinician's view of the PET. If there are any questions, I'll be happy to answer. Thank
Thank
you.
you so much. Thank you so much. You really for sharing all your interesting cases. So I think the most fascinating I found was the scar and the tattoo sarcoids, They
Yeah.
were really out of the box. So the second, the third, I think the tattoo sarcoid, the calcium was way too high. So, and
Yeah.
the
He came
creatinine
with that.
also
We couldn't
high.
make out, but he was treated elsewhere for AKI.
Yeah.
And he came, they treated the AKI as emergency, treated the hypercalcemia and left him as some sepsis. And he was still going around. He says, you are treated, but the fever is still going on. So we are not able to make out. They were attributing to the CRP raised to the obesity. So sometimes it can get muddled up, and you can always be good to be a physician, so you can step back and think you can say non renal
If it
or
was
non.
older, I would have thought of ruling out multiple myeloma also.
Yes.
Other thing, Dr. Solar, we are in Pune with him. So he started doing FAPI PET scan.
Okay.
So we have found two cases where the usual PET dermatomyositis cases, where normal routine PET was normal, and then FAPI is fibroblast activation protein inhibitor.
Okay.
So there he discovered some occult malignancies which were not found on the routine PET.
Okay.
Yeah, and the three cases of the iotitis, idiopathic, vasculitis. Did you also look a little for Behçet over there?
Yeah. We did Behçet's HLA testing and other history, but somehow here the Behçet is not that common. We do have it, but it's of much less severity.
Yeah, it is just that they were relapsing again and again. So
Yeah.
And the first case of chronic EBV. So what happened to the patient finally?
Patient actually just got sick of all these chemotherapy. He said he's going for Ayurvedic and he lost it all. So that is a problem. They are from Kerala. They actually moved away from Chennai to settle in Kerala. They got, actually both of them were working 3 cycles of chemo, drained all their savings. They just
I think there is no real treatment for chronic EBV infection.
yes. But what I have done in many cases, I kept them on low dose of steroids. They kept it at bay, not beyond anything. Little bit of anti-inflammatory drugs and steroids, though it is not a cure, but at least they are symptom free in certain cases. So 2-3 cases I know that they are actually doing well, because somebody had started on long-term antiviral as a you can say as a empathetic use, though no clinical evidence. Somebody said, why don't you take antivirals for a long? Risk is there, but with the antiviral, in that particular case, she became better and she's off all drugs. And the entire 2-year follow-up was only in online. I've never seen that patient. They kept on following up, and nowadays it's remote medicine also works. Sometimes I feel.
Any other questions from the audience? Students, any questions? I think they're just, in awe of all the wonderful cases that they saw. Excellent
I just
collection.
collected it and
excellent
basically,
collections. Very happy you could share them. Thank you so much.
Yes,
Thank you for sparing your time on a Sunday and joining us
pleasure
for
to
this session.
how do you say, teach the young minds, because I always say that they are better than us and we should make them better than us. That's it.
Looking forward to more interactions with you. Thank you, sir. Good day to you. Okay,
thanks, ma'am.
goodbye.
And thanks for a very good initiative you're doing. So thanks a lot.
See you soon. Bye-bye. Good day to
Good day, ma'am. If you come to Chennai, please do drop in.
Yes, absolutely. Thank you. Bye-bye.
Good day.